Let's jump right into this explainer. Today, we're unpacking a real heavy hitter in modern pharmacology, the macrolide family. Whether you're a nursing student grinding for the NCLEX or you just want to know how we fight off some seriously stubborn microscopic invaders, this is for you. We're going to explore exactly how these drugs work, who they're for, and those absolutely crucial safety alerts you've got to keep in mind. So what do walking pneumonia, whooping cough, aka pertussis, and a severe penicillin allergy actually have in common? Take a second. It kind of sounds like a random medical trivia question, right? But these actually all fall perfectly into the crosshairs of the macrolides. It's a great example of just how versatile these meds are in the real world. When our standard frontline defenses fail, or when some really tricky bacteria crash the party, this is the exact drug class providers reach for. You can think of macrolides as the heroic penicillin alternative. As we know from our source material, a huge chunk of patients out there have hypersensitivity or even life-threatening allergies like anaphylaxis to penicillins. And since cephalosporins can sometimes trigger a cross-allergy, healthcare providers are often left scrambling for a completely different structural class of antibiotics to safely treat gram-positive infections. Enter the macrolides. They step in beautifully to save the day for patients who literally wouldn't have many other safe options. Okay, so how do they actually pull this off on a microscopic level? Well, macrolides are generally bacteriostatic. Now, that means they don't just burst in and kill the bacteria outright. That would be bactericidal. Instead, they basically hit the pause button. They freeze the bacteria, stopping them from growing and replicating. By freezing the bacterial army in its tracks, macrolides give the patient's own immune system the time and the upper hand it desperately needs to just sweep in and clear out the infection. But how exactly do they hit that pause button? Well, I want you to burn this number into your brain right now, 50. Macrolides work by binding directly to the 50S ribosomal subunit inside the bacterial cell. By latching onto that specific target, they completely jam up the bacteria's ability to synthesize proteins. And, without new proteins, the bacteria simply cannot grow or divide. End of story. Because of that incredibly precise 50S targeting, we get a massive hit list. The sheer variety here is wild. We've got your standard respiratory issues, right? Community-acquired pneumonia, bronchitis, standard skin infections. But macrolides also totally excel at taking down what we call atypical pathogens, the sneaky ones that cause walking pneumonia, like mycoplasma or Legionella. They're also an absolute go-to for sexually transmitted infections like chlamydia, severe coughs like pertussis, and they even act as a critical prophylaxis and treatment for Mycobacterium avium complex, or MAC, especially in HIV patients. Section 2. Meet the Big Three, a pharmacological family portrait. First up, we've got erythromycin. You can think of this one as the grandparent of the macrolide family. It's the absolute prototype, the oldest drug in the class, the one that paved the way for all the others. But, just like an old cell phone or a vintage car, it comes with a few clunky features that the newer generations definitely had to improve upon. For starters, because erythromycin is the oldest, it demands frequent dosing throughout the day just to keep working. It also has a notorious reputation, really notorious, for causing the most intense gastrointestinal upset in the entire class. We're talking severe nausea, vomiting, abdominal pain, diarrhea, the whole shebang. To make things even trickier, you usually have to take it on an empty stomach for proper absorption. Oh, and at really high doses, it carries a rare but super serious risk of ototoxicity, meaning it can actually damage a patient's hearing. Moving down the family tree, we meet clarithromycin. This is the middle child. It basically took what worked with the grandparent and made some solid upgrades. The dosing schedule, for instance, is way better, usually just twice a day. Plus, you actually should take clarithromycin with food, which is great because it significantly cuts down on all that nasty GI upset. But this middle child has a major hidden flaw you absolutely have to watch out for. Let's break this down step by step because this is a massive drug interaction. Step 1. Clarithromycin is a powerful inhibitor of the CYP3A4 enzyme in the liver. Step 2. Because that specific liver enzyme gets blocked, other medications the patient might be taking just can't be metabolized or broken down normally, which leads us to Step 3, a dangerous chain reaction. Levels of other really common drugs, think statins for cholesterol, warfarin for blood thinning, digoxin for the heart, they literally just build up to toxic levels in the bloodstream. If you've got a patient on a complex list of meds, clarithromycin can throw a massive wrench into their metabolic machinery. And finally, we arrive at azithromycin, which you probably know by its brand name Zithromax, or just the classic Z-Pak. This is absolutely the golden child of the macrolide family. It is by far the most commonly used today. Why? Well, it mostly avoids all the drama of the older generations. It causes way fewer GI side effects than erythromycin, and crucially, it has far fewer drug interactions than clarithromycin. Honestly, comparing the oldest to the newest really shows you how much this class has evolved. Erythromycin is a total hassle. Frequent dosing, horrible GI distress, super short half-life. Azithromycin, on the flip side, is a breeze. It boasts a super convenient once-daily dosing schedule. And here's the real magic of the golden child. It has an insanely long half-life and amazing tissue persistence. So a patient might only take a short 3 to 5 day course of pills, but the drug actually sticks around in the body's tissues, actively fighting the infection for days after they swallow that very last pill. Section 3. Red flags and warnings. Critical safety alerts. All right, I really want to spotlight this quote from our source material because it is absolutely vital. NCLEX alert, monitor for QT prolongation and CYP450 drug interactions. If you are a nursing student or just prepping for any medical board exam, flag this in your brain right now. Test writers are literally obsessed with asking about these specific cardiac and metabolic risks, mainly because missing them in a real clinical setting can be fatal. So looking at the overall adverse effects, GI distress is for sure the most common across the board. But jumping to the heart, macrolides can cause QT prolongation on an ECG. If a patient is already at risk for cardiac issues, this can trigger a lethal heart rhythm, known as torsades de pointes. Providers will very often order an ECG just to check if a patient is high risk. Moving down to the liver, macrolides can trigger a rare but thankfully reversible condition called cholestatic hepatitis. And of course, just like with any antibiotic, you've always got that lingering risk of hypersensitivity reactions and superinfections, where wiping out one bacteria suddenly gives something else, like a nasty fungus, the room to overgrow. Which brings us to a completely non-negotiable point of client education. You must tell the patient to complete their full course of therapy. Even with azithromycin's super short 3 to 5 day regimen, patients start feeling great by day 2 and think, hey, I'll just save the rest of these pills for next time. Stopping early is a recipe for disaster. It basically just leaves the strongest, most resilient bacteria alive, which promotes antibiotic resistance, rendering the drugs completely useless the next time the patient gets sick. And that actually leaves us with a really fascinating question to wrap up today's explainer. Because azithromycin uniquely persists in body tissues for days after that final pill, how might this golden child change the way we combat antibiotic resistance in the future? It's kind of a double-edged sword, right? On one hand, shorter courses mean better patient compliance. People are way more likely to finish a 3-day Z-Pak than a grueling 14-day regimen. But on the other hand, having these lingering, subtherapeutic levels of the drug just hanging out in the tissues over a long period could potentially give bacteria the chance to slowly adapt and mutate. It is a crazy, complex pharmacological puzzle, and scientists are still working hard to solve it. Thanks for hanging out with me for this explainer on the macrolide family. We've looked at the heroic penicillin alternative, we met the grandparent, the middle child, and the golden child, and unpacked those critical safety alerts you've got to know. Keep learning, keep questioning, and I'll catch you next time.